Hi, once again welcome back to Obstetrics and Gynecology videos. Today we are going to see about the antepartum fetal surveillance. That is, what are the investigations or diagnostic tests we can perform for identifying the problems in the baby and for identifying the complications that can occur for the baby. 80% of the fetal death is occurring in the antepartum period, or death of the baby is occurring in the pregnancy stage. And the major causes for this death include hypoxia for the baby, that is inadequate oxygenation for the baby, intrauterine growth retardation of the baby, that is also maybe due to the improper supply to the baby, even other maybe due to other problems also it can occur, and complications of the mother like diabetes, hypertension, infection, and congenital malformations of the baby, and because of other unexplained causes also this death can occur. And the primary objective of antenatal fetal assessment is to avoid the fetal death and such complications. The monitoring methods that we are using mainly in this period include clinical monitoring, biophysical monitoring, and biochemical monitoring. The clinical monitoring includes checking of the maternal weight gain. See, already I have told you that the mother is supposed to gain 10 to 12 kilogram of weight during the pregnancy. So you should see whether the mother is getting that weight. Blood pressure of the mother, fundal height, that is size of the uterus. Already we have seen all these things. Abdominal girth, assessment of the size of the uterus, amniotic fluid distribution, edema of the feet. These are the things mainly we are assessing in the clinical monitoring. See, I think no need to give special explanation for these points because all these points we have seen in the antenatal care and physiological changes during the pregnancy. Now we can see the special investigations, that is in the earlier pregnancy. Already I told you that we are doing biochemical, biophysical, and we can do cytogenic test also. The biochemical test that we are doing, especially in the early pregnancy, include maternal serum alpha fetoprotein, triple test, and acetylcholine esterase test. Alpha fetoprotein, maternal serum alpha fetoprotein, triple test, and acetylcholine esterase test. This alpha fetoprotein is an oncofetal protein produced by the yolk sac and the fetal liver. And the highest level of this alpha fetoprotein can be seen in the fetal serum and in the amniotic fluid at about around 13 weeks of pregnancy. And the highest level of alpha fetoprotein can be seen in the maternal serum around 32 weeks of pregnancy. And usually we are performing the test between 15 to 20 weeks of pregnancy. And in case if the maternal serum alpha fetoprotein level is high, it suggests the following conditions. It may be due to the wrong gestational age, or maybe due to the neural tube defects of the baby, that is open neural tube defects of the baby, or multiple pregnancy, intrauterine fetal death, anterior abdominal wall defects, and renal defects of the baby. In case if the level is high, you should suspect these conditions. The next test is triple test. In the triple test, we are assessing three parameters, that is maternal serum alpha fetoprotein level, levels of HCG, and levels of estriol. The maternal serum alpha fetoprotein level is 10 ng to 150 ng per ml at around 32 weeks, and HCG levels already we have seen in the diagnosis of pregnancy. In case if you are having any confusion, you can see the video about the diagnosis of pregnancy. And serum estriol level will be 4 nanomole per ml at around 15 weeks, and it will be 40 nanomole per ml at about 40 weeks or at term. And this we are using mainly to detect the Down syndrome. If the levels are high, it suggests the Down syndrome for the baby. Next one is acetylcholine esterase. This acetylcholine esterase elevated levels you can see in the case of neural tube defects of the baby. Next is cytogenic test. The cytogenic test include amniocentesis, chorionic villus sampling, and cordocentesis. Now we are going to see the amniocentesis. This is a procedure in that we are just taking the amniotic fluid from the amniotic sac and we are assessing it for the various, we are testing it for the various purposes. And for obtaining the sample, or how to get the sample means, per abdominally you are inserting a needle and under the guidance of ultrasound USG through the needle you will be taking the amniotic fluid, and this needle you will per abdominally you will insert it into the uterus and it will enter into the amniotic cavity, and all these things should be guided under the ultrasonography, and from there you can aspirate the amniotic fluid. So you can see the picture over here in this series, that blue colored, it for the easy understanding they have shown it as blue color. We know that it is transparent, it's clear, and here they have aspirated it directly. Here they are visualizing the entire thing under the ultrasonography. The diagnostic indications include, in the earlier months, that is between 15 to 20 weeks, this test we can use for identifying the sex-linked disorders of the baby and for identifying the karyotyping and for assessing the inborn errors of metabolism and for identifying the neural tube defects of the baby. And in later months, this amniotic fluid, if you are assessing, you will get a clear picture about the fetal maturity and degree of fetal hemolysis. In the case of RH incompatibility, there is a chance for destruction of RBC and how much it has occurred, that we can identify, and you can identify whether it is a meconium stained, that is whether the baby has passed the meconium or not. If the baby has passed the meconium, that also you can identify by observing the color of the amniotic fluid. Next, therapeutic indications include, in the first half, this amniocentesis. Amniocentesis means inserting, already I told you, we are taking the amniotic fluid and we are performing the test. So when you are inserting the needle, you can instill certain chemicals in the first half of pregnancy, and by inserting that chemicals, we can induce abortion. So that is one advantage or one use in the first half of pregnancy for inducing abortion. We are using this method. And another one, repeated decompression of the uterus in acute hydromnias. In the case of excessive amount of amniotic fluid that we are calling as polyhydramnia, in order to reduce the amount of amniotic fluid, we can aspirate some amount of fluid and you can maintain the normal fluid level. And in the second half of pregnancy also, same for decompression of the uterus in the case of unresponsive complaints of polyhydramnias, and for the fetal transfusion, if the baby is having any problem and if you want to give blood transfusion, that is for twin to twin transfusion syndrome, or that is if the blood is passing from one baby to the other baby in the case of twin pregnancy, that is twin to twin transfusion. So in that case we are supposed to give blood and other products to the baby from where the blood is losing, that is fetal transfusion. And for amnio infusion, if you want to insert some medications into the amniotic cavity, for that also we can use this amniocentesis. So these are the uses in the first half and the second half of pregnancy. Next one is chorionic villus sampling. We know what is chorionic villi. Already we have seen it in the placental development. And the chorionic villus sampling is helping for prenatal diagnosis of genetic disorders. And usually we are performing it transcervically, that is not per abdominally. Through the cervix, we will insert a needle around 10 to 12 weeks of pregnancy. And in case if you are doing transabdominally, we can do it at around 10 weeks and till term. That is up to 12 weeks you can do it transvaginally, and after that you can try for abdominal. And when you are inserting it, it should be under the guidance of the ultrasonography, and a villi will be collected from the chorion frondosum under the ultrasonic guidance with the help of a long malleable polythene catheter introduced transcervically along the extraovular space. So that is, this catheter we will be introducing through the cervix. This actually here, this picture is showing the catheter. See, here it is introduced, and we will locate the placenta, and from the chorion frondosum of the placenta they will take few villi. and it provides a diagnosis within 24 hours. And the complications of this procedure include there is a chance for loss of the baby, there is a chance for oromandibular limb deformities, there is a chance for vaginal bleeding, and the complications are high when comparing to the amniocentesis, because when we are inserting this needle, especially sometimes it may be difficult for you to locate the placenta exactly. And another thing, when you are inserting it transvaginally, mostly the placenta will be in the upper segment of the uterus or in the upper portion of the uterus. So when you are inserting, there is a chance for damage to the baby, and there is a chance for even bleeding also. And sometimes you may get a false result, or you may get a negative result, because the maternal cells also may contaminate the specimen. Otherwise, placental mosaics also will be there. In these cases, you will get the negative result. In such cases, you should do the amniocentesis in order to confirm the diagnosis. And in case if the mother is having the my husband is having the opposite blood group, if the Rh negative mother is there and if the husband is positive, in that case you should give anti-D in order to prevent the Rh incompatibility. Next is cordocentesis. This is percutaneous umbilical cord sampling. That is, we are taking the sample from the umbilical cord. That is, all the information that we are getting from the amniocentesis and chorionic villus sampling can be obtained from the cordocentesis also. Along with that, we will get information about the fetal anemia, bleeding disorders of the baby, and hemoglobinopathies. These also can be identified. And if fetal infections are there, that is toxoplasmosis are there, if viral infections are there, that also can be identified. And fetal blood gas and acid base status also can be identified. And if the baby is having hypoxia, that also can be identified, and we can identify the intrauterine growth retardation also. And this we can use for the fetal therapy, and even for transfusing or for giving blood to the baby also we can use it. Next is biophysical. In the biophysical, the first method is ultrasonographic examination of the fetus. By the ultrasonography, by taking the ultrasonography, we can identify or assess the crown rump length, that is the length from the tip to the bottom, top to bottom of the baby. And if it is smaller than the gestational age, it suggests severe fetal anomalies, and we can identify the nuchal translucency. If it is high, that also shows abnormalities, and you can, if absence of nasal bone is there, means that also can be identified. And antepartum surveillance in the late pregnancy. This also include clinical, biochemical, and biophysical. The biophysical tests that we are usually performing in the late pregnancy include fetal movement count, cardiotocography, non-stress test, fetal biophysical profile, Doppler ultrasound or ultrasonography, vibroacoustic stimulation, contraction stress test, and amniotic fluid volume. First, let us see about the fetal movement count. For this, we are using the Cardiff 10 count formula. In this case, we will just advise the patient to, or instruct the patient to, count the fetal movements for 12 hours. In 12-hour time, if she is getting less than 10 movements, and if it is happening for continuously for 2 days, or if she is not at all able to perceive even a single movement in 12 hours, or that is in a single day, this has to be reported. This is an abnormality. Normally, in a day, she will get minimum 10 movements, and usually if it is not there, it suggests the problems. Next, another method is daily fetal movement count. In that case, you can instead of counting continuously for 12 hours, you can advise the woman to count for 1 hour in the morning, noon, and in the night. And after that, how much she is getting, she can multiply it with the 4, so that she will be getting the daily fetal movement count. So that is one method. And if the fetal movements are less, this suggests the abnormality. And if fetal movements are not there, usually it will be followed by the absence of fetal heart rate, and sometimes it may end with the death of the baby within 24 hours. Fetal heart rate will not be there, and after that, death of the baby also can occur. Next one is NST or non-stress test. Nowadays we are using it very commonly, and it is using the principle of Doppler only. And over the abdomen we are keeping an ultrasound transducer, and this will be assessing the fetal heart rate, and a tocodynamometer also will be attached over the abdomen, or will be strapped over the abdomen. You can see in the picture, in this way we will be attaching, and this will assess the uterine activity, and these two things are attached to the abdomen. And this is based on the hypothesis that fetal heart rate of a fetus that is not acidotic due to hypoxia will accelerate in response to the fetal movement. That is, whenever the baby is moving, along with that, or because of that, the fetal heart rate also will increase. It is very simple. When you are doing exercise, your heart rate will increase. Same way, when the baby is moving, baby's heart rate also will increase. So this based on that principle only. And if it is reactive, that is, if it is positive, if there is no problem for the baby, means you can just presence of 2 or more fetal heart rate accelerations during a 20 minutes period. With each acceleration, that is, you are expecting that minimum 2 movements will be there for the baby in 20 minutes period. So whenever the baby is moving, you will get the acceleration or hike in the fetal heartbeat, and this acceleration will be of for 15 beats per minute, and it will be lasting for minimum 15 seconds, or sometimes maybe for more, and usually occurring along with the fetal movements, and the tracing is extended to 40 minutes before commenting it is non-reactive. So continuously, even if you are not getting after 20 minutes also, you are supposed to watch for 20 more minutes. Continuously you have to watch for 40 minutes. See here, this shows the fetal movements of the baby. So whenever this hike is there, this line indicates the movements of the baby, and see, when this hike has occurred here, this is the fetal heart sound. See, it was moving like this around almost in a steady way, but when the baby has moved, there's a strike. Again, here the baby has moved. Again, you can see an acceleration. So this is the normal NST. That is, there will be an acceleration for around 15 beats per minute, and that will be lasting for 15 seconds. See that hike you can see for 15 seconds. And if it is non-reactive, so you just see this. Sometimes baby may not move, and sometimes if the baby is moving also, this hike will not be there. This fetal heart rate is smooth without any irregularities. Usually it is associated with the fetal hypoxia. Other causes, sometimes the baby may be sleeping. In that case, the baby may not move. Because of that also, you may get this type of result. And if the baby's gestational age is less than 28 weeks, in that case the movements will be very less, or it may not be even significant. In that case also, you may get this type of graph. But in other cases, if the baby is moving and still if you are getting a straight line, it suggests the fetal hypoxia. And along with the straight line, sometimes you may get the decelerations. Sometimes the fetal heart rate may come down. The graph will come down. Deceleration, if non-repetitive and brief, are not significant. That is, if the deceleration is for a short period and if it is not getting repeated, it is not significant. But if it is occurring repeatedly, that is 3 in 10 minutes, like that, and if it is for a prolonged duration, that is, if it is lasting for more than 30 seconds, that should be considered as abnormal. That is, if it is moving steadily, you can suspect whether the baby is sleeping, or sometimes gestational age may be less than 28. But even during this time also, if reduction in fetal heart rate is there, this is not normal, that is abnormal. And if that reduction is occurring only once in a time, we cannot consider that it's abnormal. If it is occurring continuously, that is, if it is getting repeated, and if the duration of that reduction is lasting for 30 seconds, more than 30 seconds, it is abnormal, and it shows the fetal hypoxia. Next one is VAST, that is vibroacoustic stimulator. In this case, we are attaching an vibroacoustic stimulator over the abdomen, and this will apply a stimuli over the abdomen for 1 to 2 seconds. And when the baby is getting this stimuli, that is, it's making a sound as the stimuli, and when the baby is getting this sound, hearing this sound, it will stimulate the baby's heart rate, and that will produce the acceleration in the heart rate of the baby. And actually this is due to the startle reflex. See, in the pediatrics you might have seen, when the baby is hearing a sudden sound, almost all of a sudden when the baby is hearing the sudden sound, the startle response will occur, and that is the complete fanning of the fingers, movement of the extremities, everything will occur, and because of that movement only here we are getting the fetal heart rate acceleration. And if that acceleration is there, we can tell that it is reactive, VAST is reactive. And if it is not there, that is after the sound stimuli also, if the baby is not getting the fetal heart rate acceleration, the test is non-reactive. Next is contraction stress test or CST. It is otherwise known as oxytocin challenge test. It's based on the fact that when the uterus is getting contracted, the blood supply to the fetus or to the placenta will decrease due to the contractions of the uterine muscles. When the uterine muscles are getting contracted, the blood vessels also will get contracted, and due to that contraction, supply to the baby will decrease. Actually, this CST is based on that principle only. And a normal fetus is able to withstand this hypoxia. That is, when the fetal supply is decreasing, naturally baby will get the hypoxia or decreased amount of oxygenation, and normally the baby will withstand this stress without difficulty. But if the fetus is with acute or chronic problem, it will not be having the capacity to withstand this decreased oxygen supply, and this will result in late decelerations. That is, after the contraction, after few seconds, after some time, the heart rate of the baby will decrease. That is late deceleration. And if at least 3 spontaneous contractions lasting for 40 seconds is present already, if it is there already, no need to give oxytocin. Otherwise, we are supposed to give oxytocin. If not contractions are there, we are supposed to give oxytocin through the oxytocin infusion. And this test gives an indication whether the fetus will withstand the stress of labor or not. So when during the time of labor process, the uterus will be contracting vigorously, and if that time, if the baby is getting hypoxia, if the baby is weak, the baby won't be having the capacity to withstand that contraction, and that may produce the fetal distress. So for identifying or for predicting the fetal distress, you can do this. For predicting the fetal distress during the time of labor process, we can do this test. But the disadvantages are, it is time consuming. After giving the oxytocin, we have to wait for the onset of contractions, and we have to wait and see. And it is invasive, and sometimes, rarely, after giving the injection, the baby may get, or the fetus may get, the severe fetal hypoxia. These are the disadvantages of this CST. Next is biophysical profile, otherwise we are calling it as Manning score. In this we are assessing 5 sets of variables, and it can be used to decide on the timing of delivery in high risk cases and in the case of intrauterine growth retardation. And if the biophysical profile score is low, it is always associated with the absent and end diastolic blood flow. And normal variables are given a score. If the variables, that is, we are assessing 5 variables over here, and if the variable is good, we are giving 2 score, and if it is abnormal, we are giving 0 score. If it is normal, we are giving 2. If it is abnormal, we are giving 0. And the indication is, that is indication for this Manning score is, in the case of non-reactive NST and in the case of higher risk pregnancies, we are doing it. And the test frequencies, we can do it weekly after a normal NST, and if the NST is not normal, we can do it twice in a week. Already I have told you that we are assessing 5 parameters in biophysical profile, and these parameters include fetal breathing movements, fetal tone, fetal reactivity, and amniotic fluid volume. And these parameters, or by this Manning score, otherwise we are calling as fetal Apgar. After the delivery, we are assessing the normal Apgar immediately after the birth, but this is known as this is always named as fetal Apgar. So now let us see in detail about these parameters. First one is fetal breathing movements. If at least 30 seconds of sustained breathing movements are there in 30 minutes of observation, means it is normal, we can give the score 2. And if the fetal breathing movement is less than 30 seconds of observation, 30 seconds in 30 minutes of observation, the score is, test is the non-reactive, you can give the score 0. And next is fetal movements. If 3 or more in 30 minutes and if simultaneous limb and trunk movements are there, we can give the score 2. And if 2 or less movements in 30 minutes, in that case the score will be 0. And next is fetal tone. If one episode of motion of limb from flexion to extension and rapid return to flexion in 30 minutes, the score is 2. And if the fetus is in semi or full limb extension with no return or slow return to flexion, the score is 0. And the fetal reactivity, if 2 or more accelerations at least 50, and if it is that is acceleration for 15 beats and per minute lasting for 15 seconds, and if it is associated with the fetal movements, that is we are checking the NST. And if we are getting 2 movements and 2 accelerations, and if the accelerations are lasting for 15 seconds and if the acceleration is for 15 beats, we can give the score 2. And if there is no accelerations or less than 2 accelerations in 20 minutes of observation, the score is 0. Here also it is 20 minutes. I think I told 30. Make it as 20. And next is amniotic fluid volume. The pockets of at least 1 centimeter in 2 perpendicular planes are there, means you can give the score 2. For this we are supposed to do the ultrasonography. And if the largest pockets are less than 1 centimeter in 2 perpendicular planes, the score is 0. So these are the parameters we are checking in the biophysical profile. And the scoring and interpretation, if the score is between 8 to 10, it shows no fetal hypoxia, and if it is less, it shows fetal hypoxia. And if it is between 8 to 10, no need to worry about it. We can repeat the test on the next week without any problem. And if the score is 6, it suspect chronic asphyxia. And if the baby is above 36 weeks, we can go for the delivery of the baby. Otherwise, you should repeat the test in 4 to 6 hours. And if the score is 4, here also you can suspect severe or chronic asphyxia of the baby. And if the pregnancy is above 36 weeks, we can go for the delivery of the baby immediately. And if it is below 32 weeks, if the delivery is occurring, it will be difficult for the baby to survive. You just repeat the test in 4 to 6 hours and confirm the problem. And if the score is less than 2, it indicates strong asphyxia, and the test is 120 minutes. If persistent score is there, repeat the test in 120 minutes, and if persistent score is less than 4, go for the delivery of the baby regardless of the gestational age. So that's all about the interpretation of the biophysical profile or Manning score. Next is modified biophysical profile. It consists of NST, ultrasonography, and amniotic fluid index. That is, these 3 things you can do along with the biophysical profile. And if considered abnormal, if NST is non-reactive and if the amniotic fluid volume is less than 5 centimeter. Now we are going to see about the fetal cardiotocography. In this we are mainly assessing the fetal heart rate. At 32 weeks, if you are assessing the fetal heart rate, the normal fetal heart rate will be between 110 to 150 beats per minute. And there will be a variation of 5 to 25 beats per minute. Variation means that doesn't mean that it will decrease, only accelerations will be there. And there will be minimum 2 or more accelerations in a 20 minutes period. And there should not be any decelerations. And if a deceleration is there, and if it is for short duration, very short duration, and if it is an early deceleration, it may not be an abnormality. But usually decelerations should not be there, only accelerations will be there. Next one is ultrasonography. By the ultrasonography, we can identify the intrauterine growth retardation. We can measure the biparietal diameter, abdominal circumference, head circumference, fetal length, and amniotic fluid volume also can be identified. And abdominal circumference is a measurement of nutritional status of the baby. If the head circumference and abdominal circumference ratio is elevation, that is if it is more than 1, after 34 weeks of pregnancy, it suggests the growth retardation of the baby. Next is Doppler ultrasound velocimetry. That is, Doppler flow velocity waveforms are obtained from the arterial and venous blood in the fetus. Arterial Doppler waveform is helpful to assess the downstream vascular resistance. It is used to measure the peak systolic, diastolic, and mean volumes. Systolic, diastolic, and mean volumes can be identified. From these values, we can calculate the systolic-diastolic ratio, pulsatility index, that is PI, that is equal to systolic minus diastolic by mean volume. Or we can see the resistance index. This resistance index is systolic minus diastolic divided by systolic. And in normal pregnancy, the systolic-diastolic ratio, pulsatility index, and the resistance index decreases as gestational age advances. Higher values greater than 2, that is if the systolic-diastolic ratio is greater than 2, above the gestational age, means it indicates a reduced diastolic velocities and increased placental vascular resistance. These features point towards the adverse pregnancy outcome. That is, if the placental resistance is high, naturally the blood supply to the placenta will decrease and it will affect the outcome of the baby also. So the normal waves or velocimetry will be, the waves in the case of the waves will be like this, but if diastolic velocity is reduced, the waves will be like this, and if diastolic velocity is absent, the waves will be in this form, and if reversed and diastolic velocity, end diastolic velocity is there, means you can see the depressions or downward movements also will be there in the velocimetry waves. Venous Doppler parameter provide information about cardiac forward function, that is about the cardiac complaints, contractility and afterload. Fetus with the abnormal cardiac function show pulsatile flow in the umbilical vein, and normal umbilical vein flow is monophasic. That is, if problem is there, cardiac problem is there, means pulsatile type of flow will be there in the umbilical vein. Usually it should be monophasic without that pulsatile movements. Now we can see the Doppler changes and features suggesting the compromised fetus or problems of the baby. In the umbilical artery, if you are observing reduced or absent end diastolic flow, it shows the pathology of failure of villus trophoblast invasion. And the clinical significance is, because of this, increased resistance in the fetoplacental circulation will be there, and because of the increased resistance, the supply to the baby will decrease and chance for intrauterine growth retardation and preeclampsia is there. And if middle cerebral artery, you have to observe, and when you are observing, if increased diastolic velocity is there and decreased systolic diastolic ratio or pulsatility index is there, means it shows the dilatation of the cerebral veins, and it suggests the brain sparing effect in response to hypoxemia. That is, it shows severe hypoxemia. And next we should observe the ductus venosus. Higher Doppler index, absent or reversed flow is there, means it will be due to increased central venous pressure, and it suggests the fetal acidosis. Next we should observe the umbilical vein, and increased Doppler index is there and pulsatile flow is there, means that is pulsatile wave. If it is not monophasic, if it is pulsatile, it shows increased central venous pressure or decreased, there is a chance, or cardiac complaints. So this also suggests the fetal acidosis or acidemia. It is compulsory that you should see the amniotic fluid volume in the pregnancies which are complicated. That is, in the case of intrauterine growth retardation and in the case of preeclampsia, it is compulsory that you should see the amniotic fluid volume. And if amniotic fluid volume is less, it shows, or it can occur due to decreased uteroplacental perfusion, and if the placental supply is less, that leads to decreased blood flow to the kidneys of the baby, and if the blood flow to the kidney is less, means the kidney the filtering amount from the kidney also will decrease, that is the urine production also will be decreasing, and we know that the main contributor to the amniotic fluid towards the end of the pregnancy is fetal urine, and if the urine production is less means that will produce the oligohydramnia, and oligohydramnias can occur due to preeclampsia, intrauterine clotted dilatation, premature rupture of the membrane, and if renal agenesis is there, that is of only one kidney is there for the baby, and if there is an obstruction is there in the urinary tract, in these cases you can see the oligohydramnia or reduced amniotic fluid. Next we can see how to see the amniotic fluid volume index A5. The amniotic fluid volume is calculating by dividing the uterus into 4 quadrants, 4 areas we are just dividing, and we will measure the largest vertical pocket of liquor in each of this quadrant. Then after that we should add the length or the measurement what we have received in each quadrant, that we have to add together, and that its sum will give you the amniotic fluid index in centimeter, and the normal amniotic fluid index is between 5 to 25 centimeter, and if it is less than 5 centimeter it suggests the oligohydramnia, and if it is more than 25 it suggests the polyhydramnias also. And the other tests that we are doing in the late pregnancy include test for ensuring the fetal maturity and assessment of the severity of RH isoimmunization also. So far we have seen all the important biophysical, biochemical and cytogenetic tests that we are using during the antenatal period in order to identify the high risk pregnancy and to identify the fetal complications. Thank you for watching this video. See you once again with a new video.